My work revolves around looking at the quality of blood used for transfusion, and my interest in this is because blood is an important component of managing critically ill patients. Especially the burden lies within the pediatric admissions and postpartum hemorrhage patients. So my interest in looking at the quality of blood is as a result of the poor outcomes that the critically ill patients get despite receiving this a limited and scarce commodity. And the main users of blood within sub-Saharan Africa are mainly pediatric admissions. These are children under 5, and also pregnant mothers who get postpartum hemorrhage after deliveries. So the question is are they getting enough blood, and why are they having poor outcomes? Is it because they're not being given the right product, or the quality of the product is not the best for them, or is impeded by quite a number of factors as a result of the processes involved in the preparation and storage of this product? In terms of looking at asymptomatic infections, then it is important because as I mentioned before, the people who receive these products are critically ill patients. So you wouldn't want, for example, to transmit infections via transfusions. We call them transfusion-transmitted infections, TTIs. For example, malaria. So a patient has come, they have severe malaria anemia, which is causing the low hemoglobin. Then you're giving them a product that potentially has the risk of transmitting malaria to them. So you'd want to ensure that whatever product we are giving is free of such infections that are not normally screened. The main infections that are screened for are hepatitis, HIV, and syphilis by the blood transfusion services. So for particular regions, depending on transmission intensities, this might be important or maybe not. So we really need to know. The other thing is for governments to lobby for governments to actually support blood transfusion services now that we don't have a lot of support from external donors. We need to show them that whatever we are actually giving out is actually a good product, because at the end of the day, if a patient is not getting blood that's good enough, then they'll end up coming in for retransfusion. So you have downstream readmissions, which you can actually give the patients a product that is good enough for them to recover to the required HB levels. Then they don't have to come back to hospital. And then also blood transfusion services is not able to do research. So the research will be carrying out, and we're working in collaboration with blood transfusion services in our country. Then they have evidence to present to the Ministry of Health to lobby for screening for like early on HIV infections, which requires nucleic acid testing, which has not yet been enrolled within the system. So I believe we are creating evidence that KEMRI directly needs to lobby to governments for funding and also for improved quality of blood. My work revolves around, I have two aspects. So the first aspect is working within an already ongoing clinical trial that's looking at transfusion to children with severe anemia. So in that trial, I get samples from the patients as well as from the pints of blood that they use for transfusion to these particular patients. Then I can look at various aspects in both that would link the donor to the patient who actually receives the blood by looking at the quality of blood that they actually receive.